Hello and welcome to this installment of the Building Research Acumen in Neuropsychology seminar series. I am Dr. Travis Shively-Scott, MyRec Neuropsychology Research Fellow at the VA Palo Alto and with affiliation at the Department of Psychiatry and Behavioral Sciences at the Stanford School of Medicine. Today, I'll be presenting on the neurocognitive aspects of traumatic brain injury. This presentation is designed to provide a brief overview of traumatic brain injury, types of traumatic brain injury, including post-concussive syndrome and CTE, relevant brain imaging findings, including neuropsychological features of traumatic brain injury, and overall outcomes and recommendations for patients with TBI. Before we get started, I must disclose that I am an employee of the United States government and Department of Veterans Affairs. As such, the information today does not represent the views of the US government or VA. Views expressed today are my own. I also have no conflicts of interest with regard to any of the content presented today. So to start, it's important to define traumatic brain injury, also known as TBI. A TBI can be defined as a blow or jolt to the head that disrupts the normal function of the brain. This is in contrast to a head injury that does not disrupt the normal function of the brain. So what differentiates a traumatic brain injury from a traditional head injury with no other features is that a traumatic brain injury disrupts how the brain is functioning. TBI can also be categorized based on severity, with the three main categories being mild, moderate, and severe. It's important to note that severity is determined at the time of injury. It's also important to note that concussion is often commonly used synonymously with mild traumatic brain injury. Now some basic TBI facts. In terms of prevalence of TBI, a study by Dewan and colleagues in 2018 found that globally, as much as 69 million people sustain a TBI each year. This study explored the prevalence of TBI by region in the world and found that North America was had the most common or highest prevalence of traumatic brain injury of anywhere in the world, where nearly 1,300 per 100,000 individuals sustained a TBI each year in this region. In terms of common causes of TBI, the two most common causes of TBI are falls and motor vehicle accidents. But it's important to note that the order of these common causes differs depending on brain region in the world. So for North America, falls and motor vehicle accidents are ranked 1 and 2 in terms of most common causes, respectively. Whereas in other parts of the world, for example, Africa or Southeast Asia, motor vehicle accidents are actually more common. And in these regions, motor vehicle accidents actually make up over 50% of all TBIs. Other common causes include sports-related injuries, such as blows to the head or hits to the head from playing football, American football, rugby, and other sports. Violence, such as gun violence, or military-related TBI. Risk factors for TBI include age, and specifically, TBI is most common in infants and children, and then also very common in the elderly. And the reason this is because if you think about, again, looking at our most common causes, falls being among one of the most common causes of TBI, it is infants and elderly or children who are most likely to sustain a fall. And that could be due to developing or deteriorating motor functioning, and also developing or deteriorating cognitive functioning. And in terms of cognitive functioning, risk-taking is highly associated with TBI. And so those individuals who are children or teens or the elderly may engage in more risky practices or they basically put them at risk for a TBI. including just not being careful or being in situations where they may be engaging in some risky activities. In terms of sex, men sustain TBI more often than women. Low SES is associated with high rates of TBI, including low education, unemployment, and low income. Lack of safety equipment is also highly related to traumatic brain injuries. So not having a helmet or seatbelt. And in fact, it's found that wearing a seatbelt reduces mortality as related to TBI by up to 50%. And finally, drug and alcohol use is also highly related to traumatic brain injury prevalence. Moving on to TBI severity. So now we'll go ahead and we'll define what a mild, moderate, and severe TBI means. But to do that, we have to understand some common definitions. These include loss of consciousness, post-traumatic amnesia, and the Glasgow Coma Scale. Loss of consciousness is defined as a period of time in which the person is non-responsive. Post-traumatic amnesia is defined as a state of confusion after a TBI, where the person is unable to form new memories. Now, to assess this, it's important to note that you would ask questions the days that follow the traumatic brain injury to gauge whether or not the person can recall events that have happened since the traumatic brain injury. So, for example, if you ask, what did you have for breakfast this morning? And you're asking that on a day after the traumatic brain injury, if the person isn't able to remember this event, then it's likely that they're still in a state of post-traumatic amnesia. The Glasgow Coma Scale is a specific measure that's used to assess a patient's level of consciousness and responsiveness immediately following a TBI. This scale is typically given by among the first medical professionals who see the patient after they've sustained the traumatic brain injury. So, for example, an EMT or an ER doctor would often give the Glasgow Coma Scale. And we'll talk more about the scores in the Glasgow Coma Scale, which range from 3 to 15 on the next slide. So here are the criteria that define TBI severity. One final item that helps determine TBI severity that we didn't mention on the last slide is imaging, specifically neuroimaging. Now, for concussion or mild traumatic brain injury, neuroimaging is typically normal, meaning that there are no abnormal neuroimaging findings. The brain looks like it should look. If this is the case, the person's mild traumatic brain injury or concussion can be considered uncomplicated. However, it is possible to have positive neuroimaging findings with a mild traumatic brain injury or concussion. This would then be classified as a complicated mild traumatic brain injury or a complicated concussion. Additional criteria for mild traumatic brain injury and concussion include loss of consciousness for under half an hour, post-traumatic amnesia for less than a day, and a Glasgow Coma Scale score of 13 to 15. Now, it's important to note the Glasgow Coma Scale, the higher scores represent less impairment and less problems with regard to consciousness. The person is more aware and responsive the higher the score. So these scores are pretty good. Whereas in moderate traumatic brain injury, neuroimaging is typically abnormal. Loss of consciousness tends to range from 30 minutes to a day. Post-traumatic amnesia can last up to a week. And the Glasgow Coma Scale scores are lower, around the range of 9 to 13. In severe TBI, it's very, very likely you're going to see abnormal neuroimaging, so problems with the brain, loss of consciousness for over 24 hours or over a day, post-traumatic amnesia for over a week, and an initial Glasgow Coma Scale of only 3 to 18, meaning the person is minimally responsive and possibly in a coma state. A final scale to mention, which is not on this slide, that is especially important in the more moderate to severe traumatic brain injuries, is the Rancho Los Amigos scale. This is especially important in determining moderate to severe TBI because it contains items that assess a mix of questions looking at coma, post-traumatic amnesia, agitation, and ability to follow commands following the injury. This scale is especially useful for not only diagnosing moderate or severe TBI, but also to determine the amount of supervision or help a person needs and to get a general idea of gross progress and recovery timeline. Moving on now to some of the other interesting diagnoses that are related to traumatic brain injury. We'll start with PCS, or post-concussive syndrome. Now, at this point, you may be thinking, on the last slide, we just talked about concussion. Now we're talking about post-concussive syndrome. What are the differences? And the answer is, there's not too many differences. And in some sense, the differences are somewhat blurry. The main difference is that in individuals who typically sustain a concussion and have typical recovery, the typical recovery for recovery from symptoms, especially cognitive symptoms, is about a week or so. Those cognitive symptoms especially tend to remit over the course of about a week. This study was on American college football players. I'll point it out right here. And it showed that on average, most of these football players, again, their symptoms, especially cognitive symptoms, remitted after about 7 days. Whereas in post-concussive syndrome, both physical and cognitive issues tend to last for at least 1 to 3 months after the TBI. Now, this diagnosis is somewhat controversial because it is highly related to mood. And in some cases, it's hard to disentangle the effects of the traumatic brain injury from those of associated psychological conditions like depression and anxiety. But common symptoms for post-concussive syndrome include somatic head symptoms like dizziness, headache, sensitivity to light and sound, cognitive problems such as attention and concentration, memory, some executive issues like decision-making and judgment, and also behavioral changes, not just depression, but also irritability and sleep problems. But again, it's important to note that if the symptoms persist for more than a few months, especially once you get outside of the 3-month range, and maybe even start getting worse, then you're moving away from a diagnosis of post-concussive syndrome, and then it is much more accurate to probably say that the persistent symptoms are a byproduct of additional factors outside of the head injury itself playing a role, such as mood, depression, anxiety, and so on. So again, this is a controversial diagnosis, but it is a possible feature of concussion that can occur in some individuals. Moving on to CTE, or chronic traumatic encephalopathy. So this is also somewhat similar to mild traumatic brain injury / concussion, but in this case, CTE is thought to be caused by exposure to repeated concussions, or repeated multiple traumatic brain injuries. This idea is that these repetitive head impacts, sometimes subconcussive, meaning not quite at the level of concussion, spur complex brain changes which lead to a neurodegenerative process called chronic traumatic encephalopathy, so actual brain changes. Now, for these individuals, they have similar cognitive impairments as individuals who sustain a concussion and reporting post-concussive syndrome, such as issues with memory, attention, and executive functioning. But these individuals also have behavioral changes such as verbal and physical violence, rage, quick temper that aren't really characterized in concussion. In addition, while they also tend to have high rates of mood issues like depression and anxiety, CTE has also been thought to be associated with motor problems, such as Parkinsonisms, so issues with gait and tremor. But again, overall, this is also a controversial diagnosis. And it's in part by how difficult it is to diagnose CTE. And as we'll talk about later, CTE is only diagnosed after death. So in living individuals, it's very difficult to make this diagnosis with any sort of certainty. Now, in terms of some similarities and differences between CTE and mild traumatic brain injury concussion, just to hit these points home. Again, CTE is thought to be caused by repetitive concussions or repetitive mild traumatic brain injuries, while mild traumatic brain injury and concussions are a single injury, according to the criteria we just covered on the previous slides. Additionally, like CTE, which is thought to cause a neurodegenerative process, there have been studies that have found a small but significant risk of dementia following a single mild traumatic brain injury. But the caveat to this is that that really this is with older adults and not so much with younger adults. So younger adults who sustain a single concussion or mild traumatic brain injury, there is very limited evidence that a neurodegenerative process may play a role in their cognitive abilities. Again, as I just mentioned, big distinguishing factor between CTE and a single concussion or mild traumatic brain injury is that CTE cannot be diagnosed while the person is alive. And because of this, the descriptions of the clinical features are often based on interviews with family members of the deceased individual, which again poses a lot of problems in terms of how the symptoms are reported. Versus a mild traumatic brain injury or concussion, the diagnosis is actually, it has to be made soon after the injury itself. For CTE, the total number of cases is unknown. It's a newer diagnosis. It's really been the last 10, 15 years that we have really come to learn any information about CTE. Versus we've already talked about mild traumatic brain injury, concussion, and TBIs overall, so we know that those are pretty common. Finally, with regard to cognitive testing, while there can be some deficits that show up on testing for TBI and concussion, as we've talked about, really for CTE, there have been known to be some cognitive problems in CTE, but the research shows that there really is no distinct cognitive profile, where really one particular cognitive domain is more impacted more frequently than others. So moving on now, away from TBI severity and now to TBI mechanisms, let's first go over an overview of what we're going to be talking about when it comes to mechanisms of TBI. So we'll start by discussing the different mechanisms of injury, so primary injuries versus secondary injuries. Then we'll move on to the head injury types, so open head injuries versus closed head injuries. And then we'll move on to different brain injury locations that can occur in TBI, such as focal, diffuse, or mixed. We'll define those terms on the following slides. So, in terms of primary brain injury, for the mechanism of TBI, this is an important distinction. So, a primary brain injury due to TBI is actually the direct injury to the brain at the time of the trauma or injury, right? And so, taking this picture as an example here, right? The primary brain injury would be, in this case, the IED blast, right? That caused a blast wave that led to shrapnel entering the brain, that led to brain movement. These are all things that happen at the moment of injury. This is an important distinguishing factor between primary and secondary, which we'll cover on the next slide. Common injury mechanisms include the direct impact itself when the injury takes place. Often there is rapid acceleration, deceleration at that time. Blast waves are a common primary injury mechanism. And penetrating injuries, these open head injuries can occur. But now moving on to secondary brain injuries. So while we have that instant where the head injury occurs, that's the primary brain injury. The secondary brain injury are the additional changes that occur in the brain in the hours or days after the trauma. So after the head injury happens and the person immediately starts going into recovery, there are still changes that are occurring in the brain that are delayed changes. These things include cellular changes, actually. So neurotransmitter mediated exotoxicity So the neurotransmitters are starting to have problems. Electrolyte imbalances, mitochondrial dysfunction, inflammatory problems, cell death. These are all things that can occur in the hours or days after the traumatic brain injury. Not due to the immediate impact of the injury, but again, following some time that's passed. Other things that can happen are contusions or brain bruises, edema, which is swelling, intracranial pressure, so a buildup of pressure in the brain, hemorrhages, which are brain bleeds, and other factors, as you see here listed, also can occur, including secondary changes due to surgery effects or seizures and things like that. So now let's move on to the different types of traumatic brain injury. And there's two basic types. There's open head injuries and closed head injuries, right? So you have your, again, at the instant the brain injury happens, is there basically is the skull penetrated? If that's the case, this is an open head injury. These are actually only make up about 10% of all TBIs. And just like any TBI can basically lead to primary or secondary or both injuries. For open head injuries, these penetrating injuries, these tend to produce focal changes, which means these very specific changes in the brain, basically localized or basically pinpointed at a particular site in the brain. However, as you see in this image here, which is an example of a gunshot wound, the fact of the bullet entering the skull, going through the brain, it also can cause secondary changes and changes that actually are farther away or more diffuse from the site of injury. So things like midline shifts with the ventricles moving. So these can also happen with these open head injuries. Some common brain injury findings we've already talked about when we covered the difference between primary and secondary brain changes. So again, because you can have both primary and secondary brain changes, you see these effects here for these open head injuries. Moving on to closed head injuries. These are, again, the most common form of traumatic brain injury. Just like open head injuries, these can lead to both primary and secondary brain changes. But these injuries tend not to produce just focal changes. They tend not to just produce changes in one specific part of the brain. Again, because there's nothing basically getting into the brain. Nothing is protruding the skull and going into the brain. This is these more macro changes, these bigger changes that are occurring due to a variety of causes, as we've already talked about, in terms of the primary brain injuries, right? And because of that, what you often have with a closed head injury is this phenomenon of coup counter coup. You see here in the image to the right. What coup counter coup is basically, this is an injury where the brain rebounds and hits the opposite part of the skull. So what you have is your brain in your skull is buoyant. It's floating in the CSF that is inside of the skull in the area of the cavity, the skull cavity. The brain is floating on it. When you have a closed head injury and you have rapid acceleration and deceleration. So again, take the example of a person falling and hitting their head on a fixed object like this. Well, the brain will accelerate forward. That's the coup injury. And then after it accelerates forward, because of the law of physics, and there's no friction on the brain, it's just floating, it then accelerates backwards. And that's the counter coup part. That's where, again, the brain is basically hitting the front part of the skull and then hitting the back part of the skull. And that can cause injuries at both regions of the brain. Contusions and lacerations, so brain bruising, can also occur, as you can imagine, due to this coup counter coup. And then finally, there's this other phenomenon called diffuse axonal injury. This is due to these closed head injuries, and again, due to the rapid acceleration, deceleration movements that go on in these closed head injuries. You can actually have shearing of axons. Again, if you have hopefully learned in one of the other brain lectures, axon is part of your nerve cells, right, in the brain, your cells of the brain, and the shearing of this particular region of the nerve cell can cause a host of problems. And patients with severe diffuse axonal injury typically present with profound coma, unfortunately. And so, this can be a real serious injury that takes place as a result of these closed head injuries. Moving on to the neurocognitive profile of TBI. Because traumatic brain injuries can occur at any particular region of the brain, if you take, again, the example of an open head injury, take, for example, a bullet, a bullet can enter and exit at any particular point of the brain. Because of that, the neurocognitive domains that can be affected by TBI technically are any single cognitive function depending on the site of injury. But there are some more common sites that are typically impacted due to TBI, some more common cognitive domains. The main cognitive domains impacted in TBI include especially the frontal lobe functions, such as executive functioning, attention, and aspects of memory that require some of the executive functioning skills, such as taking the information in from the outside world. And the reason that these frontal lobe functions are often most impacted in TBI is goes back to what we were talking about on the previous slide with coup, counter coup, and the brain moving in the skull. And what can often happen in a TBI is basically what you have is you have these, if you look here, if you look at the skull, you have these bony protrusions that exist in the frontal regions of the skull. And this particular area is called the cribriform plate. And so when you have a traumatic brain injury and you have the brain, moving rapidly in the skull, what happens is the brain, as it's moving, often scrapes over these bony protrusions and actually makes contact with the surface of the brain, which can lead to damage in those areas. Because those areas are in the frontal part of the skull, that leads to usually changes in the frontal parts of the brain. So again, issues with executive functioning, attention, even things like irritability, impulsivity, mood lability, which is rapid mood swings. So those are some common problems in terms of cognitive problems due to some of the anatomy of what's impacted in TBI. Other common areas that are impacted depending on severity include language and other aspects of memory. And it's important to note that the cognitive outcomes in TBI are often associated with the neuroimaging findings. They're also associated with other injuries that occur at the time of the TBI, again, the particular brain regions it's impacted. And there's other correlates with, other associated features such as, age, vascular problems, lack of oxygen to the brain. There's a whole other host of issues that can influence the cognitive problems that present in TBI. So if we break down the neurocognitive profile of TBI by severity, it's important to note that in mild traumatic brain injury and concussion, we've already touched on this. Again, the attention is often going to be one of the most common domains impacted. You may see some problems with verbal memory, but it would be more related to slower processing speed. You might see some word finding problems here and there, but really, attention and some mild executive issues you might see in mild traumatic brain injury. Versus moderate to severe, executive functioning is going to be the core feature of these more severe injuries. And where you might even see behavioral problems. Again, the impulsivity, mood lability we talked about on the last slide are often very common in the more severe forms of traumatic brain injury. The attention and processing speed problems are also going to predominate. They're going to continue like you would see in mild traumatic brain injury. But you also may see many more memory problems, such that memory has this kind of dose-response relationship with severe TBI, in that the more severe the traumatic brain injury, the worse the memory often can be, and such that with real severe TBI damage, the memory damage could actually be permanent. And then finally, with regard to language, which is another domain which we've talked about a lot being impacted in traumatic brain injury, it's important to note that while there can be language impairments, especially in the more moderate to severe forms of TBI, it's definitely not all aspects of language. The most commonly impaired areas in terms of language include verbal fluency, confrontation naming, which again is that word finding skill, and comprehension. Now moving on to TBI outcomes, so prognosis by severity. And it's important to differentiate between TBI and concussion and moderate to severe TBI. MTBI, mild traumatic brain injury and concussion. So in terms of recovery for MTBI and concussion, it's typically 1 to 3 months of recovery to baseline. Again, sometimes even faster, but for at the most, for those individuals who may be having some post-concussive syndrome. Versus moderate to severe TBI, you typically see, really looking at the course and the recovery trajectory. That's really where you're going to be able to tell the long-term outcome. And it's important to know in MTBI, the acute injury characteristics, what actually happened at the time of injury, how the person's looking immediately following the injury, are not really that related to the outcome. Again, because there's a lot of mood factors that come into play, and because the cognitive issues in mild traumatic brain injury concussion are quite mild and often very minimal, the acute injury characteristics, what happened around the time of the injury, not going to be that related to the outcome. Versus moderate to, and basically, again, these other factors are going to be related, like these non-injury factors, mood, like we just said. Versus in moderate to severe TBI, this is going to be very much, the outcome is going to be very much predicted by the severity of the injury and the acute injury characteristics, like what did the person look like right after the injury. For mild traumatic brain injury and concussion, it's unclear whether the kind of long-term disability is due to neurologic issues or due to psychological factors. Versus moderate to severe TBI, it's pretty clear that the persistent disability is due to the severity of the injury, like what actually happened to the person, the neuroanatomy related to what parts of the brain were disrupted, and then those resulting impairments. Moving on to TBI outcomes by severity for these other conditions we've talked about, PCS and CTE. For PCS, we've already touched on this a little bit, but just to give you kind of a breakdown of typical recovery for PCS, actually over 90% of individuals with post-concussive symptoms and syndrome do tend to show symptom recovery by 4 weeks post-TBI. And only less than 5 have persistent difficulties. And again, these individuals, the difficulties, at that point, it becomes hard to tell if it's due to the head injury or due to these other factors like mood. So it's overall important to intervene early for both short and long-term outcomes. For CTE, in terms of recovery and outcomes for that, for individuals who have just sustained maybe a single concussion, or maybe they just sustained a concussion and they had one in the past, it's really important to educate these individuals about traditional recovery in concussion. Their recovery is going to look a lot like the recovery we've already talked about for mild traumatic brain injury, concussion, PCS, etc. So that's going to be really important. And it's also going to be important to note that the symptoms that people experience with CTE, which we've talked about, they're also experienced by people with other conditions. So even beyond just the concussion symptoms, the mood symptoms, which are experienced by a lot of people with other problems, even some of the irritability and other factors of CTE that differentiates that, they're also common in other conditions as well. So again, it's going to be important to note the limitations of the CTE diagnosis and note that it's going to be hard to really separate those things. Now, for individuals who are coming in and maybe they've sustained a concussion or mild traumatic brain injury months or years ago, it'll be important also to provide some education. But for these individuals, they're going to maybe already have a better idea of concussion recovery, especially if they've sustained more than 2 concussions. But it'll be important in these individuals to really treat these comorbid problems, the things that are also occurring in these people. Because again, the more time that passes since the injury, the more likely it is actually not due to injury factors, and it's due to other factors that they're still having problems, be it physical or cognitive. So it's going to be really important to treat those symptoms. And then also to really address mental health. Because in both CTE and PCS, psychiatric factors like depression and anxiety often are really present and kind of on the forefront, that one of the main features and problems with these individuals. So it'll be really important to address and treat those factors in individuals with CTE. That will show the best overall outcomes. In terms of just general recovery for TBI, regardless of severity, it's important to note that most individuals make the largest gains in recovery within the first 6 to 12 months following the TBI. And this is why it's critical to intervene and offer rehabilitation during this time frame. Now, rehabilitation can work in these individuals because the damaged brain regions that occur as a result of the traumatic brain injury can actually recover and resume some functions early on in the recovery process. And this is known as neuroplasticity. In addition, in terms of compensation, with rehabilitation, patients can compensate for their loss of cognitive abilities and even see functional improvements even years after injury. And this brings me to another kind of side note, especially for those interested in neuropsychology. Cognitive rehabilitation is a service that can be offered by neuropsychologists. And, especially with traumatic brain injury, there's actually research showing that there's a lot of positive outcomes for cognitive rehabilitation in improving individuals who sustain TBI, improving their cognitive abilities. But it's important to differentiate between, let's say, restorative cog rehab and compensatory cognitive rehabilitation. In the former, in restorative cognitive rehabilitation, this is really occurring in the first few months after the injury, where you're trying to bring the person back to their previous level of functioning, to improve their cognitive skills so that they're back where they were at. Versus compensatory cognitive rehab really does offer individuals who maybe even are outside of the recovery window, or maybe their injury is so severe that they're not going to be able to recover their previous cognitive functions. It still offers these individuals useful skills and strategies for how to work with their current cognitive abilities, their new level of functioning. And so the research does show that rehabilitation in either format can be useful for basically all the cognitive domains that are often impacted in TBI. And even though executive functioning isn't listed here, it's important to note that cognitive rehabilitation often does focus on executive functioning as one of the domains to improve in individuals who sustain TBI. Finally, just to wrap up, some overall TBI recommendations. First and foremost, it'll be really, really important to manage patients' symptoms, especially early on, right? Not only cognitive, but also physical and even psychological symptoms. That'll be key. And then providing education to the patient and family about typical recovery. If recovery is expected, what is the realistic recovery profile depending on the severity of TBI? It'll be important to emphasize recovery and the gradual resumption of work and social responsibilities, especially for those individuals at the more mild forms of traumatic brain injury. The research actually shows that the longer you hold off on going back to work and kind of getting back to where the person was, especially in the milder forms, the more psychological issues someone can have, and the longer their recovery process may take. Compensatory strategies and environmental modifications we've talked about can be very important to work with the person where their current level of functioning is. Early intervention should especially make use of non-medication, like cog rehab, like we talked about. And then other things like sleep hygiene and relaxation might be important, given that sleep is often disrupted in TBI. And again, we've talked about the associated psychological features of many of these traumatic brain injuries and how relaxation can actually help that. And then finally, because when a person sustains a traumatic brain injury, they are at risk for other neurologic complications such as seizure. It'll be important to minimize the use of alcohol and drugs that may lower the seizure threshold, that is, put the person at risk of sustaining a seizure. So it'll be important to have the person reduce their alcohol intake, reduce their use of stimulants, and so on. So that's all for this presentation today. I want to thank you very much for sticking all the way to the end of this presentation. I also want to thank Dr. Ruben Robbins for inviting me to speak today. And I want to thank several psychologists at the VA who have graciously shared their slides that have helped create this presentation. Here are the references for this talk, and this now concludes this segment of the Brain Seminar Series. Thank you.